Thankfully, they're not the situations that most health workers work in every day, but the fact that those acts, those atrocities happen apparently in impunity, I think adds to a sense that many health workers may have that experiencing violence and harassment and the mental health and psychological strain has somehow become normalised and is part of the job. So that feels as though it's an immense challenge that we are facing, and we may have quite a significant gap between policy and practice as well, and we want to explore that in this session. The reason all of this matters, and I know I don't need to say it, but important for the record, that we have evidence, overwhelming, solid and credible evidence from across the professions that the well-being, the safety of the workforce is directly correlated to the safety and the well-being of patients, and incidents of risks and harm and untoward incidents of patients increase where the health workforce is not supported. We want to dig in a little about whether, though, when we talk about psychological safety and health and well-being, as well as the policy practice gap, do we really understand what we mean by psychological safety, and are we living in practice the policy ambitions that are clearly stated? For example, we talk about needing to eliminate a blame culture, have a just culture. But Neelam made the point in her session this morning that the level of legal protection is still shockingly low. Some of you may be familiar with an example from my profession, from nursing, of Nurse Redonda, who was a nurse in the US. She made a drug error which tragically resulted in the death of a patient. She had missed warnings in the process of drawing up the drug and administering the drug, and when when she was aware of her error, she put her hands up and she honestly and she openly reported that she was subject, and she alone, the only nurse, the only healthcare worker who was subject to criminal prosecution was Redonda, and she was convicted criminally of negligent homicide in 2022. The American Nursing Association, the International Council of Nurses, we all made statements about our concern that this could have a really chilling effect on nurses and other healthcare workers to speak up. And everything that we might say here about having just cultures and open cultures, a case like that can set back our work really very, very quickly and rapidly. And it's not just as having a dramatic case like Nurse Redonda from Tennessee in the US. If you are in a workplace, nurses tell me this, you're in a workplace and you have raised a concern, but the response is you don't really understand, your colleagues don't agree with you, you're perhaps being disloyal to your organisation. If you're dismissed in that way as an initial response, that also sends a very powerful signal to other healthcare workers about speaking up and speaking out. And I think that we also need to recognise and put on the table that gender has a huge part to play here. Overwhelmingly our healthcare services are delivered by women. Discrimination, inequality, gender-based violence, deeply rooted and are integral, I think, to this discussion that we're going to have on psychological safety and health and well-being. We heard this morning moral injury. It's another concept that we talk about, and we describe that in a way that you see harm and the impact it has on you as a healthcare professional of seeing harm. Nurses who I talk to also describe, when we have this conversation about moral injury, they describe something which they refer to as feeling professionally compromised. You're trained and you're educated to a high standard. You have professional codes of ethics and regulators for healthcare professionals that rightly set the standard very high. Most codes of practice and ethics say your primary duty, rightly so, is to the patient. The patient, service user, must come first. But then if day after day you see in your practice not enough staff, lack of equipment, you're rushing from one person to another, you know that you're not giving care to the standards that you've been educated to and you're going to be held accountable to as well. Erosion on your morale, on your mental health well-being. Ultimately, I think we're seeing some of that translate through into burnout, anxiety, people leaving the profession earlier than they otherwise would have done. And just on the shortage point, WHO have just recently had to revise their estimate of health worker shortage, which they thought we were on track to be short by 10 million by 2030. That's still a huge number, but revise it up to 11 million. We have stalled or arguably gone backwards in the last few years on addressing global shortages. So, to get into this session, understanding what psychological safety is, what we mean by it, but then to try and explore how do we translate from a macro, from a policy level into practice, to identify what we think some of the barriers may be to operationalising policies that work, what the actions are that we want people to be taking. I think importantly as well how we might measure all of those things. But not to forget that we meet here as an international group and body as well, and what can we also bring at a global and international level, as well as our work within organisations and at a country level as well. So, Dr. Haruki, Harry, as he's kindly allowed me to call him, Matsumoto. First to you, sir. Thinking about the macro level, how can government policy effectively promote psychological safety within the workforce and to protect and support well-being for patients and staff?
Thank you, Howard, arranging the session, and thank you, everyone. I would like to say about promoting psychological safety. Please show my slide 1, Q1. Yeah, the question is, how can government policy effectively promote psychological safety within healthcare system, ensure that well-being both patients and healthcare workers? So yeah, very complex, yet crucial priority, I think. Yeah, promoting psychological safety within healthcare system is challenging and policy issue, yet it is vital for balancing the well-being of both patient and healthcare workers. This is very challenging issue, but it is essential to tackle, and we need to share at every level it is solvable. And why psychological safety matters? Very obvious question for you all, but this is a Patient Safety Summit, so we should share these questions' importance. We must underscore its importance and share it with various stakeholders. And the reason 1, psychological safe and supportive environment significantly reduces medical errors, of course. And secondly, when healthcare workers are encouraged to share concerns and mistakes without fear and punishment, not subject, that they detect correct errors, are strengthening both safety and quality of care. This open dialogue culture also fosters continuous learning and radical implement. And 2 government laws I would like to mention. The first, the government must clearly state the importance of psychological safety and drive momentum among multiple stakeholders. By publicly emphasizing its value, officials can inspire collective action and raise awareness on a national scale. And secondly, a robust framework, legal is very important. Legal, regulatory, and cultural framework is essential. And for example, government can mandate standardized stress check, limit excessive working hours, and enforce transparent reporting system. to embed psychological safety into daily operations. These three initiatives are a feasible approach that have already been implemented in Japan. Thirdly, incentive, money, and strategic investment further sustain these efforts, resilience, as well as offering public payment scheme for teams with advanced patient safety training ensures that psychological safety remains a long-term priority. That I would like to mention, effective promotion of psychological safety in healthcare ultimately demands coordinated policy action at every level. That these are very important. Thank you.
So, Harry, you identify here a very clear leadership role for government, quite interventionist, but also with incentives, some of which you said were financial incentives as well. Tell us more about how governments can be convinced to make these investments, and if they're asking for the value for money proposition from making these investments, how do we make that case?
Yeah, there are two negotiations. There are within healthcare and between healthcare and budget office. So the first one, it is easier to persuade other area of healthcare, like general or the high quality care. That the share of the budget idea. So the evidence-based talking is important to other area of healthcare. And it is more difficult to persuade budget office, like financial ministry. So the political momentum is very important. So like the case of suicide of nurse or the social movement, like you mentioned, subject some nurse like that, the policymakers should seize momentum to persuade the budget office or other stakeholders, I think. Thank you.
And finally, Harry, do you just you mentioned what's happening in your country as well, to say a little bit more about Japan's approach, the Japanese model as well?
In 2003, after the tragic case in Japan, we set the national strategic comprehensive patient safety strategy, and which mentioned psychological safe, especially for the no blame culture. And after that, we make new legislation to mandate all kind of healthcare facility, like all clinics, all hospitals, to commit patient safety by law. That's one example.
Thank you, Harry, very much. Giving us a very clear overview of what is possible at a macro level with government support. So let's move on, Dr. Saud, to think about more at a micro level, at the coal face, how well-being programs can be integrated into healthcare environments to enhance staff well-being, and give us some examples of practical approaches, best practice examples as well.
Actually, as a part of in Saudi Arabia Vision 2030, Saudi Arabia is implementing a healthcare sector transformation program. This program focuses on enhancing the value of healthcare services, access to care, and also mental health support programs, hosting many well-being events, and also investing in wellness program and wellness tourism. For the well-being program to be effective and integrated, it has to be a holistic approach. That it means it focuses on the 7 dimensions of well-being. Leadership engagement should be at the beginning, from the beginning, to show them the number, the burnout, the turnover, the absence, the economic impact on like burnout on economics. Tailored programs, it has to be tailored according to that institute. Accessibility should be accessible to all team members, because you know some of them have like night shifts or difficult to access. I remember even in COVID-19, some of the hospitals, they have some programs, but the healthcare provider cannot access because either the time or sometimes even the confidentiality issue. It has to be evidence-based intervention. Also, it has to be integrated with patient safety goals. That means to integrate it with safety protocols, incorporate the professional well-being also as a key outcome, along with side with the patient safety, with the care quality, cost effectiveness, and also monitor the outcomes like reduced absenteeism, lower turnover rates, also improve the patient satisfaction score. There are some strategies to integrate it, like adopt the quadruple aim framework, which is incorporating the professional well-being as a key outcome, along with side with patient safety, with care quality, cost effectiveness, and also use quality improvement projects to reduce the cognitive load and the streamline work flows, and enhance also both staff well-being and patient safety. Second, also to develop a comprehensive reporting system, along with allow the healthcare provider to report the potential threats to their well-being within the system. Also, leadership-driven initiatives, some educational programs on patient safety, also preventive also care and risk reduction. The best practice, I think, to start with, we should create a champion team who are interested also in well-being, and to include the stakeholders at the beginning in this team. Regular assessment to know what is the need. Also accessibility, train the trainer. Also, it's very important to cultivate the concept of well-being in the institute, and again integrate it with the safety goals.
You've given us some real nuggets of practical approaches at an organisational level. What I'm, and you've stressed leadership in the same way that Harry did as well. What I guess I'm interested immediately to hear perhaps a little bit more from you about is that how do you sustain what you've described? If you've got that buy-in with a leadership team, with the staff, at the beginning for the accessible, tailored approaches, what are the things that need to be happening to sustain that over time? And perhaps with that as well, insights you might have about when we talk about just or open or safe cultures, what do the behaviours of the leaders who are doing that, what does that actually look like if they say that they're a...
I think very important, the leadership rule is very, very important. There are maybe 4 steps that the leaders should adapt to make the psychological safety. First of all, frame the work. It means to explain the meaning at work. Second, also to navigate uncertainty in work. Sometimes we are not certain about the future, about the mistakes that might made. Second, they acknowledge fallibility. That means they recognize and accepting our own limitations. Sometimes you can ask, is there something that you can add? Maybe I missed something. Third is model the curiosity, engaging, asking question, exploration. And the fourth important one, embrace messengers. That is, invite others to communicate, to suggest, to give ideas, to criticize. Maybe this is the 4 important thing. Also, like modeling vulnerability and openness, sometimes building also trust open communications with the team, sometimes also flattening the hierarchy, which is, in the healthcare environment, often there are hierarchical structure based on the position. So leaders should work to flatten this hierarchy and to increase the psychological safety in those lower position, and to recognize also the individual difference.
Thank you again. What I'm struck by is that what you describe in terms of being very open requires a level of honesty and a level of being non-judgmental,
yeah, exactly.
as well, which are words I think we would all support. But we know that the reality of healthcare can sometimes be quite harsh, and people go to a place.
Yeah, I think that the judgmental, it's very difficult if you are judgmental to our employees. So I think implementing the non-judgmental attitude and accepting to be open to our staff, regular meeting, there is like a loop of feedback. This is very important also to make this culture, and also part of it, train the trainer or train the leaders to cultivate also this concept.
Thank you very much, Dr. Saud. Let's move on to Dr. Anthony Staines. Dr. Anthony, we talk frequently and often about the fact that we need systemic fixes, that there are system-wide weaknesses of fault lines that we need to address and to incorporate our safety strategies across organisations, across healthcare systems, which can be very, very complex. And quality improvement programmes are often central to improving care. So tell us a little bit more of your experience and your work on how quality improvement programmes support the creation of psychological safe cultures and well-being.
With pleasure, thank you. And let me start my presentation with an example. I run a quality and safety improvement program for a federation of hospitals in Switzerland, federation of 12 hospitals, and we've worked for about 15 years on improving patient safety culture. This means that we assess patient safety culture every 3 or 4 years with a survey called the Hospital Survey on Patient Safety Culture, developed by AHRQ in the US. And to gain deeper insights, we've added one socio-demographic question to the survey, which is the hierarchical level of the respondent. So we have 4 levels. One is board member, one is upper management, you can see that on the slide. The third one is ward manager, and the fourth one is frontline staff, so no managerial responsibility. And so we segment the presentation of our results according to these 4 hierarchical levels. And you can see here on the slide 2 dimensions of the AHRQ Patient Safety Culture Survey, which has 12 dimensions. They are at the bottom right of the slide. So what does the slide say? It shows that the higher the rank, the more positive the perception of patient safety and patient safety culture, and the lower the rank, the greater the awareness of daily risks, of errors, and protocol deviations. And you can see a gap between upper management and frontline staff on the graphical illustration on the slide. And this gap suggests that leaders have an overly optimistic perception of patient safety, possibly due to filtered information or a disconnect from frontline realities. So to come back to the question, how can quality improvement programs help bridging this gap? Well, the first proposal is that quality improvement programs provide data to challenge assumptions. So QI programs generate objective, data-driven insights which encourage leaders to rethink their actions and priorities. So these findings provoke critical questions like, could bad news be filtered before reaching leadership? Am I, as a leader, aware of the challenges faced by frontline staff? And by surfacing these questions, QI programs reduce the fear of blame and enable leaders to make informed, proactive decisions. The second proposition is establishing a structured approach for reflection and action. So beyond merely collecting data, QI programs create mechanisms such as PDSA cycles, such as management reviews, such as safety huddles, that require organizations to analyze findings, initiate discussions, and take actions. The third proposal is normalizing the challenges to leadership. So a strong patient safety culture is one where questioning leadership is not just accepted, but encouraged. QI programs build systems that empower staff to challenge decisions and raise concerns without fear of repercussions. The fourth proposal is shifting from a culture of blame to a culture of learning. So instead of focusing on individual errors, QI programs emphasize systemic improvements and learning from mistakes. This shift helps create an environment where staff feel safe to report issues, knowing that they will be met with support rather than punishment. Fifth element, engaging frontline staff in identifying problems and solutions. So frontline workers have first-hand knowledge of safety risks and workflow inefficiencies. QI programs actively involve them in identifying problems, co-designing solutions, and implementing changes, ensuring that improvement efforts are practical and effective. And last, providing psychological safety training. At the Vaud Hospital Federation, our QI programs incorporate psychological safety training. We include, for instance, Team Steps, a methodology that equips healthcare workers with tools to communicate effectively, voice concerns, and support colleagues in high-stress situations. Such training reinforces mutual trust and psychological safety across teams. So wrapping up, why psychological safety matters. Returning to our survey results, which are on the screen, the stark difference in perception between frontline staff and senior leadership underscores a critical risk. Frontline workers witness daily errors, protocol violations, and safety failures. Senior leaders, often shielded from these realities, may assume processes are more reliable than they actually are. And without a clear understanding of frontline challenges, leadership might underestimate the needs for safety initiative, fail to allocate sufficient resources to patient safety, prioritize other objectives over patient safety improvements. And this disconnect creates a dangerous cycle where frontline concerns go unheard, problems persist, and staff lose confidence in the system. Breaking this cycle requires staff and safety experts to speak up. For staff to speak up, they must feel psychologically safe. And for staff to feel psychologically safe, they must work in an environment that encourages transparency, trust, and learning. This is precisely where quality improvement programs play a transformative role, fostering a culture of safety, breaking down communication barriers, and ensuring that every voice is heard.
I have not seen your data before, but what fascinates me about that is it reminds me of data that I have seen recently from the OECD. They had some reporting. It was buried a bit in one of their reports, but they had a graph which showed specific roles, like where you'll have somebody who will be a support person to somebody who's a whistleblower, an advocate to support staff if they speak up, to have an advocate or a healthcare worker representative at board meetings and levels as well. Is this something that you can do within the existing structures, or is it helpful or not to have new roles that are champions of speaking up, of safety, of whistleblowing? And I also just had one very practical question. I'd be interested what the audience view on this is as well. How many people work in organisations where the disciplinary policy says if you make a mistake but you openly, honestly report it, you will not be disciplined? Whether that explicit statement is common in disciplinary policies in organisations. If anybody does, put your hand up and let us know. No one. Which again, that's a signal. You know, it's in terms of the signals that organisations can send. But well, that's interesting. But Anthony, just before we move on this question about whether we should create more roles who are seen as champions or not.
I think we should create new roles. I think champions, mediators, people who support, help, etc. I think this should exist. You know, the data that I'm showing, it first emerged about 12 years ago in our first culture survey. And we've done the survey 5 times since then, and the results haven't changed. But one thing has changed, though, which makes me a little bit optimistic, which is that the first time this emerged, I showed it to our the executive board members of the Federation, and I was prohibited to show it to anyone else 12 years ago. They said, oh, well, that's interesting but very embarrassing, so please don't show that to our staff. And now they're admitting that we showed it. So the results haven't changed, but something, a click did happen.
You're sharing it with the world now, so yes, that's great. There's progress over 12 years, which gives us hope. So, moving on to sharing it with the world, Dr. Ashok Philip, the president of the World Medical Association, who my organisation, ICN, works extremely closely with the World Medical Association, and I would say that also with the international organisations for therapy, for dentistry, for pharmacy as well. I think we're all very conscious, those of us who are healthcare professionals who work at an international level, that it's important to try and model the type of multidisciplinary working that we encourage and we advocate for. Sometimes we might not do that as well as we hope, but that's certainly our ambition. Dr. Ashok, give us your thoughts on what the role is for international collaboration and establishing best practices for safety in healthcare systems. What can we be doing through our professional collaborations, through our work with WHO, the patient safety summits, and other organisations internationally?
Yes, thank you, Howard. And thank you to the organizers for the invitation to participate here. I think one way to answer that question, perhaps, Howard, is to say that clearly national or regional efforts don't seem to be bearing much fruit, and perhaps we have to start right up at the top at the international level. But I'm not going to hold my breath and say that's going to work because, well, it might take more than 12 years, Anthony. But perhaps we should just say what psychological safety is comprised of, because it has many components. I think there are many definitions, but I think respectful communication up, down, laterally, encouragement of ideas, an inclusive environment, those are important. There's also support for risk-taking, but I don't think in healthcare systems we want that. So one problem, I think, for psychological safety in the workplace is perhaps workplace bullying. You mentioned that, Howard. It's not just from patients or to patients or from their carers, but also within, between doctors and nurses and physiotherapists, pharmacists. I mean, there's doctors bullying nurses, there's nurses bullying doctors, that happens too. And that is something that we have to stop. Why should people who have joined a profession that seeks to serve, that seeks to altruistically improve people's lives, why should people who are idealistic and altruistic actually bully others? I mean, that is mind-boggling to me. But there are cases of bullying in our profession, and perhaps it's becoming more prevalent. Perhaps it's because young people don't tolerate bullying like us old people did. Because certainly in my country, the young house doctors tell us we are being bullied. And the old doctors, the old dinosaurs as we are called, and they always say that, but we suffered through that, why shouldn't you? But that is not the answer, of course. We suffered, but we survived. Doesn't mean that we have to make young people do the same thing. And to be more serious, when I was a houseman, one of my colleagues committed suicide. So we don't want that to happen ever. But there are, of course, a few unkind people in healthcare, but I don't think this is a major cause. The major cause is that our systems, perhaps, are not set up to sustain or encourage or enhance psychological safety. Because healthcare is a high-stress environment, that can't be helped. We have complex problems with potentially disastrous consequences deluging us all the time. Critical decisions have to be made rapidly. And not only do you have to make the decisions rapidly, you have to make sure that the teams are working swiftly and smoothly together to get these decisions implemented. And it's not one at a time. They come from all directions, all at the same time. And it's difficult to say which is more important. And then when things go right, the satisfaction, you feel it, but it's brief. And the success is rarely acknowledged by anyone above you because it's expected. We are the victims of our own success. Medical progress has been so good that we are expected to save people, whatever condition they come to us in. But if anything goes wrong, then finger pointing, fault finding, that's immediate. And except in a very few situations, I think almost all healthcare systems around the world, they say they are looking for the causes, but they're really looking for someone to blame. And this is not really, this is, I think, probably a recipe for inducing post-traumatic stress syndrome in the workers. It's not conducive to psychological safety. We can't remove stress. We don't want to remove stress from the profession because we do perform better under a little bit of stress. But it can be mitigated. And most of that mitigation requires governments and perhaps supranational bodies to correct systemic issues. So that is where I think international organizations like the International Council of Nurses, the World Medical Association, the World Dental Association, the physiotherapists, the pharmacists, who are all working together in World Health Professions Alliance, can do something. One of the major factors, I think, is the shortage of healthcare workers. As you mentioned, it seems to be, the predictions at least, seem to be getting worse. We are not solving the problem. The problem is getting away from us. And I think one way that some richer nations try to solve the problem is to recruit doctors and nurses and other healthcare workers from other, often poorer nations. And this tends to make a double burden on the poor nation because they have spent money to train the doctor or the nurse or the other professional. And then after they've spent all that money, they lose not only that investment, but also the worker. He has gone off to another country. So the WMA does have a statement on ethical guidelines for this international migration of health workers. We agree that it should be based on official agreements between the, what shall we call it, the donor country and the recipient country, and so that both of them benefit. Perhaps, you know, the recipient country can pay for some of the tuition of these people who are being taken away. But we also recommend certain long-term measures, make accurate projections on medical manpower needs, train enough doctors, make their working conditions better. This goes across the board for all health workers. train enough, make their working conditions at least tolerable, and improve their remuneration, improve the benefits so that they are encouraged to stay. And also, I think we have seen some countries try to solve this problem of physician shortage by replacing doctors with less trained staff. And these people may be called physician associates, physician assistants, and they're supposed to do simple routine tasks under the supervision of doctors. But there are suggestions that there should be less supervision and widening of the scope of their duties. And the extreme complexity of the field of medicine means that the minimum 5 to 7 year period of training is not the ideal, it's the minimum. So if you want to equip people who are less trained to do the same job, that's grossly, negligent, incompetent, reckless. So I think the question you should ask the politicians is, if you are sick, do you want to be treated by a physician associate or a physician? And I think we know the answer to that. So we also would like to point out that some health systems use the term health workers instead of health professionals. Now, health professionals are highly educated and trained, licensed or regulated, and they adhere to strict ethical codes and standards, for instance, nurses, doctors, pharmacists. But health workers are not quite the same. So the WHPA, the World Health Professionals Alliance, has a statement on interprofessional collaborative practices that emphasizes collaborations between health professionals and health workers should be in the form of constant supervision and oversight of the latter by the former. So where I see international alliances and international associations having a role is in bringing forward these views, which are not our own, but those of all our members. For instance, the WMA has 115 members from all around the globe, and we have come to a consensus on this. In fact, it's unanimous. So if we all say this, then it should be easier for us to use this in our own governments, in our own countries, to emphasize our viewpoints. So that is where I see international alliances, international associations having a role in buttressing and supporting their individual members.
There is so much in your intervention just now, and I think important that one of your early points that we as the professions also are part of leadership and have that leadership responsibility. It isn't just non-professionals who may be in C-suite positions. It's us as healthcare professionals as well. And your warning, rightful warning, that when an investigation to do a root cause analysis is announced, those doing it may have the very best intentions of wanting to really understand what happened or what went on, but what might be heard by the healthcare professionals is that this is a mechanism to out me or somebody else, to put the blame on an individual. You are tempting me to go down the road of talking about international recruitment and migration, because it's a topic which we have great concerns about from the International Council of Nurses and have advocated and put policy statements out on very many. Just to tie it to your comment about physicians, associates, or new cadres of workers, I've had nurses who've said to me from Africa, African nurse leaders, it feels like the 7 or 8 high-income countries who are at the forefront of driving international recruitment activity, they come and take our registered nurses, which we've paid and educated for, and say, in return, create new cadres of community health workers. And I'm not being disrespectful to community health workers, they have a role to play, but there is a risk of substitution here as well. But you talked a number of times, you referenced a number of times the ethics, and we have a global code of practice on international recruitment which says it should be ethical. But I struggle to find any evidence of really, it feels more that it might be a veneer of being ethical rather than the reality of being ethical. That might be something perhaps we come back to later about the ethics of what we're doing and where the teeth of those are and how we live those ethics as well. But I want to move on to my fellow nurse on our panel, Miss Maria Carissa Magallanes, who is working here in the Philippines. Maria, let's go back to the millions of healthcare workers today out there in clinical practice who will be under pressure, working in a fast-paced environment, emotionally charged situations. What are the best things that we can do to offer support, genuine support and assistance to healthcare workers who are working in those very, very challenging environments?
Okay, thank you, Howard, for that question. I'm working at the Philippine Heart Center as the department manager for the special and critical care. So that would be 10 adult ICUs, the cardiac operating rooms, the cath lab, and the hemodialysis unit. So that would be very chaotic at times. Now, Howard asked me, how do we maintain psychological well-being? So the sources of mental health support strategies for healthcare personnel, I have divided it into 4. From the healthcare professional himself, he can get it from his peers or his teammates, from the management and the adaptation of the institution to the compliance to the Global Patient Safety Action Plan 2021-2030, specifically the Strategy 5.5. For the healthcare professional, he should be well rested before going to work. He should be able to respect his mind and body, the need for physical and mental respite, a reboot from his previous dense workload before he would be able to take over or carry out again safely the needs of the patients. Now, another important factor is for the management to give designated time breaks for these employees, a protected time for them to eat their meals, elevate, raise their legs, or just catching up with colleagues. Now, I remember 2 decades ago when we were embarking in our international accreditation. So we were looking at the catalog of the accreditation company, and it stated that each nursing unit should have a staff lounge. So in compliance to that, we created staff lounges just to meet that requirement. So when the assessors came in and inspected our staff lounges, they said, "Is this your staff lounge? You don't even have a couch. There's no even hot or cold water for their coffee or for their water breaks." So they have told us at least the dimension of the staff lounge for the staff nurses and other nursing personnel to have a respite from their tedious physical and psychological tasks at the bedside. Another is they should be able to ask for managerial support, especially if they have personal challenges such as caring for small children, caring for elderly family members, or balancing schedules with their spouses. So they can ask managerial support by requesting for specific schedules in order to befit their needs. So that's for their self-care. Another is these healthcare workers should not be assigned in an area which is beyond their scope of knowledge and competency, and even physical limitations. It's very, the risk is very high for a nurse who's coming from an adult care unit, and if you pull him out to a pediatric care unit, chances are the risk of having medication errors, because they really have to adjust in the dosages, in the dilutions of pediatric medications. Now, for the peer or team support just means human connection and understanding. Areas which need peer support would be, for example, working in a challenging environment wherein you are a newbie, you are an orientee, or you are dealing with an aggressive colleague, or there is constant under-resourcing, there is constant understaffing. When you're working or you're going through pressures such as taking evaluation exams, we need peer support for that. Or dealing with adverse events in the unit such as medication error or procedural error, we need team support. Dealing with situations involving moral distress, a doctor or a fellow colleague saying sexually provocative statements, that could be morally distressing for a healthcare professional. So what we did, at least in our institution, is to provide, it could be formal or informal, a preceptorship training program that provides preceptors, buddies, or shadows to these nurses. So these peers, shadows, buddies, or whatever you may call them, would aim in supporting these new nurses in adjusting to their units, or in shadowing patient safety key areas such as computing for high alert medications or concentrated electrolytes. They need their shadow. And they also need to have guidance in procedural preparation. Preparing for cardiac surgery is different from preparing for a general surgery. So that peer support just means being there and making the healthcare professional feel accepted and understood, and making sure that his experience is as important as each one of us. Now, for the management, a lot could be given by the management to the healthcare professional. First of all is the education and training. But before, I think I missed resiliency boost for the healthcare professional. Resiliency boost means attending stress management program or resiliency training programs. So with this, this would include adaptive coping skills, cognitive reappraisals, and the promotion of a healthy lifestyle. So it has been shown, studies have shown that the resiliency skills course of healthcare professionals after attending these trainings were positively affected. Now, going back to the management, how can I, as a leader, would promote psychological well-being for my division chief, for my head nurse, or for the rank and file? First and foremost would be leading by example. I should be also aware of my stress levels. I should be also be able to verbalize that I am psychologically disturbed, or psychologically stressed. It's for them to realize that, oh, our department manager is also experiencing these things. So what does she do? So what do I do? So when you say walking the talk, when a healthcare professional submits a letter of complaint or does the QR code and writes his complaint to the corporate planning division, and then they send their complaints to me, number one is to foster open communication and to create psychologically safe. When you say foster open communication and create psychologically safe space, you should do active listening. So how will you do active listening? When you do active listening, you listen to this person in a private room, preferably. Remove your cell phone. Don't look at it. give him undivided attention. Give meaning to your facial expression. You should also be able to have him finish verbalizing before you inject your opinions and your thoughts. That way, he felt valued and understood and listened to, followed by the assurance that his verbalization will be treated with utmost privacy and confidentiality. But this does not mean that you will just shoulder the problem. I have to tell Dr. Ashok, Doctor, I will elevate this to my nursing director, and probably my nursing director will elevate this to a committee that is appropriate for your complaint. In our hospital, whenever there's a complaint of sexual harassment, we have the CODI, the Committee on Decorum and Investigation, that whenever there's a sexual harassment case, we elevate it, and they have a certain guidelines on what to do, what repercussions, what consequences this involved person shall have. And another one is the provision of resources. Now, aside from me listening to this stuff, there are times that I cannot deal with this. This needs professional help. So we have in-house psychologists, we have in-house psychiatrists that would probably do psychotherapy for this staff, or probably include pharmacological therapy that is best suited for his problem. Probably he needs some anxiolytics or some sedatives, because psychologically distressed staff is an unsafe staff. So that's how I do it in our institutions.
You have given us fabulously rich range of very, very practical examples. I particularly liked your reference to the staff room. When I visit nurses in their workplace, and if I'm asking the leadership about their well-being programs or their staff issues, one of the things I often ask is, can I see the staff room, the canteen, what's the car parking situation like, or how do people get to and from work, and have you got a creche or leave policy for carers leave policy? Because those things, those practical things, are just so important to be able to, live a life that isn't just work, but to do your best at work, but to deal with all of those other demands. And if there's one theme that runs through it, it's the things that you talked about are practical demonstrations of value in the individual feeling valued. We often get asked as well, so out of all of these rich examples you've heard, which is the one to go for? What's the magic bullet? And I suspect you've all come across the research on this as well, which actually says, actually that's a mistake to think there's one magic bullet. You need to do a package of the measures that all of you have spoken about. We have a few minutes for questions from our audience, and Dr. Gabrielle is kindly going to moderate our Q&A session. Over to you.
Thank you, Mr. Howard. We now move on to our question and answer portion of this program. Kindly approach the microphone. I think we can accommodate a few questions.
Your numbers, the response from the response to the survey, great numbers, 85, 75. In a study a few years ago by JCI, the leaders, and specifically the board members, they are not, in terms of support of patient safety and awareness, they were about in the 40s to 45. So there's a big difference. Now, I need to hear your comment. What do you think, how to explain this difference? And the other point is, probably, in my view, is yes, they are aware. This is what I understood from the question that they were in the survey. But was that awareness translated into actions? Were they supportive in terms of real actions and grounds discussing patient safety matters in the board, leading initiatives and so on. Because just being aware is not enough because of the the knowledge action gap. So just a thought. I want to hear your thoughts and comment on this. Thank you.
Thank you very much. I believe that the main issue here is the difference between work as done and work as imagined. And as a leader, you tend to imagine how the work is done, which doesn't really fit the reality. I've been the hospital CEO for 10 years, and I've seen later on how filtered the information was upwards. You tend to report more good news than bad news upwards. And the higher you are in the hierarchical ladder, the most protected you are from the bad news. And also, as a leader, you see what you intend to do. You sign the memos, you sign the directives, the guidelines, etc. So you know that it's been done. But what gets to the frontline staff is also filtered downwards. And so I think the main issue is there. Of course, there is also walking the talk, and the key leaders are aware of some patient safety issues, but they're also very much aware of the financial difficulties, the challenges, the constraints, the number of other priorities. But what worries me is that people taking the ultimate decisions are people that may have some bias in their mind between the work as done and work as imagined.
Thank you very much. And we now move on to another question. Dr. Neela.
Thank you very much. So my question relates to protecting health workers from harm which happens in healthcare. So if this patient is harmed and the doctors and nurses are blamed, how do we what strategies do we put in place? And it's really fortunate to see the largest professional body of nurses and doctors here, ICN and WMA, in this room. And I have a call to action. Can the two professional bodies influence the governments, provide high-level advocacy, grassroots advocacy for legal protection of health workers through laws? And that's one. So how you could utilize the strength of the organization for advocacy on actually having laws on protection of health workers. As second, particularly for reporting and if harm occurs. And second is also at the grassroots, if you could think of having a campaign which could help raising awareness on this. And I came across an excellent campaign which the Doctors Association in the UK ran in 2018. And William is here, so you can correct me if I'm wrong. So this campaign was called Learn, Not Blame. And I think something like this, this campaign, if the Nurses Association, Federation, and as well as WMA, ICN and WMA could take forward as the key pillars of healthcare provision on the front line, that would be wonderful. Thank you.
All right. For this question, may we request Dr. Ashok and Mr. Catton to answer the question.
That is an excellent, well, I'm not sure if the question is more of a suggestion, a call to action, and one that I strongly support. The only thing is that even though we are theoretically very large organizations, we do depend on our individual members to petition or otherwise influence their governments. What we do is to provide the ethical, legal, or basically moral framework with which they can work. And you were speaking about the BMA and the learn, not blame thing, but I was always thinking throughout this thing about Dr. Hadiza Bawagabra in the UK, who had all the blame placed on her for systemic failures which led to the tragic death of a child. So even in countries where they are trying to learn, not blame, yet still this sort of thing happens. And I think it's going to be very difficult to root out this problem. And it probably is something that will have to be generational, probably. But we will definitely be I think, highlighting this issue of putting the blame culture behind this more to our members. Thank you very much.
And I also absolutely support what my colleague Dr. Ashok has said from WMA and what you're asking for, Neil. We have a long history of being pretty vocal on these issues. Perhaps they're not vocal enough. We need to do more. But we see this in many ways from ICN. This is an issue about rights for us, rights of nurses. Why should a nurse or any healthcare worker go to work and be expected to be subject to treatment or violence or conditions or lack of food or car parking or any of the issues that we talked about? Why should that be expected and that be tolerated when it wouldn't be in any other sector? And that's why I think we have a gender issue to address here as well, because I think for nursing it's often particularly how the status and the value of nursing has through its history been undervalued, under-recognised. You just need a good heart to be a nurse. You need a good heart, but you need a smart brain as well. And you don't just need to be caring, as nurses, doctors, other health workers in conflict zones are showing us around the world. You need to have courage as well. So there's some shift in the perceptions of the professions as well. For International Nurses Day this year, our theme is caring for nurses, and we'll bring forward some evidence and policy recommendations, which I think gives us an immediate hook to start to link some of this into. Neelam is very kindly going to be with us at the ICN Congress as well, which is another platform that we can use to advocate for and advance rights. And I think what's important for us as well, because it can be, sometimes I have the sense that people will hear what we might say from ICN and think, well, the nurses would say that for the nurses, or the doctors would say that for the doctors. But what we try to, yes, we are saying it for the nurses, the doctors, they have rights, but also this is integral to delivering of safe and quality healthcare for people everywhere as well. So thank you. Yes.
Thank you. We now move on to the next question. If you can state your name and organization and then the question, sir.
Good afternoon. I'm Dr. Sturger from the Southern Philippines. My question, I was actually struck by the work-life balance. Where I came from, some of the big consultants there would say it's a myth for health professionals. And my question is, how do we operationalize work-life balance in residency trainings? And then how do we stop the cycle of this, in the event that they will be graduating, they will become also consultants, they will also become disbeliever of a work-life balance. What are your thoughts on that?
All right, for this question, can we ask the insights of Dr. Haruki and Dr. Saud?
Yeah, thank you for asking. The culture, bad culture and good culture also are reciprocal and very heritage. Yes. So I think the raise awareness is first step, but because there can be you might be thinking that the problem is obvious, but at that situation the problem is not obvious for the majority. So I think raise awareness is the first step, and maybe the young physicians can address set their awareness, raise awareness. I think so. The policymaker sometimes take such kind of awareness and set the priority because nowadays healthcare is can be political issue, and the workforce shortage or burnout or leaving remote area or the suburban area is a very big problem for the policy makers. So I think it can be agenda, and sometimes young physicians can set the agenda, I think. Thank you very much for asking.
I can also add leading by example. The program directors should be also show that the importance of work-life balance on themselves and to how to balance this, and also train the trainers will cultivate the concept of well-being with the program directors that they will have more knowledge and more just to implement such important things. Its impact on the trainees and the patient also safety. So I think just for culture change, I think we have to target maybe the leaders that will cascade down to all the members within the institute.
Thank you, Dr. Saud. For our last question, yes, Dr. Abdullah.
Good afternoon, Abdullah Hausawi from Saudi Arabia. So for all people that actually flew into Manila, you went through this brilliant practice of safety in the aviation industry, which is namely the minimum equipment list. Any airplane will not take off if there is not that minimum equipment list. And if we want to look at the analogy in healthcare, look at the clinical unit. Let's think about this at the clinical unit. How many times actually we don't even have that concept? So we can, when we look at some of the units, you can see a nurse for every 10, 15, maybe 20 patients. You can see a physician who's a junior physician covering an ICU, looking after 30, 40 patients by himself or herself. Such practices and actually having a healthcare professional being in these unsafe conditions, day by day, week by week, month by month, I think it would erode also, the psychological safety. The fact that you feel that you're in an unsafe situation, some of the healthcare professionals that work in those unsafe situations, when you ask them, would you trust your own hospital or your own unit to look after your family, they would say no. So how can we, and so in an HRO setting, 100% compliance with this minimum equipment list, if we want to kind of have a call to action of starting using that, vocabulary of a minimum safety list for units, so in terms of qualified staffing, in terms of even, kind of the other resources, I think that would contribute to the psychological safety, for the staff, but more importantly, it would contribute to patient safety as well. So it's a comment. Right. Anyone that wants to also.
Right. May we have a comment, Mr. Howard, and if you can wrap up the session.
Does anyone else want to comment on? I think there's a great, and I agree as well in terms of my comments around the intensification of work, the pressure of work, being educated to deliver really high standard, not being able to do that, just the effect that has on you over time, the erosion, the wearing you down, feeling that you're not delivering to the ethical and the educational standards as well, and it makes it difficult for people to come back into health care, because once you've gone through that, you've made the decision to quit. Many nurses will feel that being a nurse is part of their DNA. It's a difficult decision to quit, and so it's not an easy fix to say have 3 months off and then come back. We tend to lose people. This issue of staffing levels, it's a contentious one in terms of mandated staffing levels. But I would just share this. When I was in the UK, I remember regularly going and picking my kids up from nursery because they were young at the time, and I'd always see the number of care workers that are on today in this nursery are 3, 4, or 5. Our ratio is 1 to 3, 1 to 4, 1 to 5. It was part of their regulations for my kids in nursery. And then I had to look after the neighbour's dog, and they said it's okay because there's a dog walker who came round, and the dog walker came round and said, sorry, I can't take today because I've already got 5 or 6 dogs. There were regulations for dog walkers, but there wasn't regulations for how many patients a nurse could look after. We know from the evidence don't think it doesn't work as well as in the UK. And I'm not advocating this as a safe staffing level, but actually there was more than 8 patients. The risks went up hugely. Obviously in ICU it's 1 to 1. You know, we'd aim for 1 to 4, 1 to 6, but you're right, it's 10, 15, 20 in some areas as well. So if you hit those levels, do you want to come in and run the risk of harm to the patient, but also what it does to the healthcare worker? Or do you say, no, we're going to have to do something to adjust, to slow the flow of people into healthcare? Because that translates to politicians about we're closing the doors of A&E, and it isn't somewhere that they want to go to, as well as they think about the numbers. So how many nurses would we need to recruit as well? I think we have to keep banging the drum on the evidence around safety, and we have to be more transparent, and for the public to be able to see and understand the information and make their decisions, because I think that might be required to shift some of the political thinking as well. But it's not easy, as you know as well. Yeah.
All right, so that ends our panel discussion, and can we have a round of applause to our panelists for a very fruitful discussion? We now move on to the awarding of their certificates. May we request our Undersecretary of Health, request the panelists to stand up, please. This certificate of appreciation is given to Mr. Howard Catton for her valuable contribution and participation in the 7th Global Ministerial Summit on Patient Safety held on April 3 to 4 at the Asian Development Bank, Mandaluyong, Metro Manila, Philippines, signed by the Secretary of Health, Teodoro Herbosa. The same certificate is given to Dr. Haruki Matsumoto. The next certificate is given to Dr. Saud Abdulrahman Alomar. The same goes to Dr. Anthony Saints. Let's give a round of applause to Dr. Ashok Philip. And last but not the least, a round of applause to Miss Maria Charisse Magallanes. And then may we request all for a group photo with Undersecretary of Health. Alright, and can we request the technicals to accompany them for a group photo? Again, and just a reminder for the participants, we'll be moving to the Experts Plenary 3 at the main hall. The Plenary 3 panel